patients that started on time.
Okay, so let's start. So, hi everyone, my name is Clara Saldarriaga. I'm the head of the cardiology program for University Pontificia Bolivariana in Medellin, Colombia. And it's my pleasure to be today with you here presenting this very interesting session about infectious disease and the ECG. So let me introduce our first speaker, which is Dr. Cynthia Yeung from Canada. She's going to present a very interesting case about the forgotten foe Lyme disease. So welcome, Dr. Yeung.
Thank you very much for having me. So my name is Cynthia. I work with Dr. Baranchuk. I'm from Kingston. And today I'd like to share a case presentation with you about a complete AV block in a young, previously healthy male. No conflicts of interest. So quickly, we have this 28-year-old male. He was seen just in an emergency department in Kingston in June, presented with 4 days of intermittent non-exertional non-pleuritic chest pain. He also had a syncopal event while walking a couple of days prior, and this was preceded by some flu-like symptoms, some malaise, shortness of breath, nausea and vomiting, rather non-specific. And he has no significant past medical history medications. This is his ECG on arrival. You see some second-degree Mobitz type 2 at a ventricular rate of 43. And as a rather junior trainee, my differential for transient causes of AV block include things like ischemia. He's not in the right demographic for ischemia. Infiltrative causes, things like sarcoid or amyloid. He did not have a CT chest as part of his initial workup.
So we can see your slides. Okay, now we can see your slides. Yes. Can you please put your PowerPoint in the full screen version?
Yeah, can you see my slides now?
Yes, but not in the full version. I think you need to do something else with the Teams in order to share the screen.
Let me see. Is that helpful? Can you see my slides this way?
Yes, we can see your slides. Yes, we can go on, and I will let you know if the slides are not moving, okay?
Are they moving now?
Can you please show us the next slide?
Yeah, is that moving? Did that change?
No, it's not changing. Okay. Yes, now it's changing. Yes, now it's changing.
Oh, let me see what I can do here. Okay. If I do that, is that helpful?
Okay, now it's better. Okay.
Lovely.
Sorry for the interruption.
About that. And back to our blood work on admission, troop was only slightly elevated. CRP and ESR were notably elevated. Going back a little bit further into this patient's history, he did have a tick exposure. We live in Kingston, which is a Lyme endemic area, and the patient actually specifically recalled being bitten and having removed some ticks approximately 1 to 2 months prior to his presentation in the emergency. We immediately drew Lyme serology, and he was empirically started on ceftriaxone for a presumptive diagnosis of Lyme carditis. So I want to take a moment, deviate from the case a bit, and overview a little bit about Lyme disease and Lyme carditis. Lyme disease is a tick-borne bacterial infection. It's caused by Borrelia. It's transmitted by the black-legged tick, or Ixodes, and the ticks must typically attach for 36 to 48 hours in order to transmit infection. The peak onset that we see Lyme disease is in the summer months, so June, July, and August here in Canada. In terms of the stages and symptoms of Lyme disease, we have the early localized stage, which gives us our characteristic pathognomonic erythema migrans rash. You see a picture of it here. It's a bit of a bullseye rash. You might also get some viral-like illness symptoms, so chills, myalgias, headache, fevers. Lyme carditis is part of the early disseminated stage of Lyme disease, and the most common presentation is atrioventricular block in 80 to 90% of cases. But of course, there can be other cardiac manifestations, from myocarditis to sick sinus syndrome to atrial fibrillation. But by far, the most common we see is AV block. And this is just highlighting that from onset of tick bite to onset of Lyme carditis-like symptoms may be on the order of, on average, 1 to 2 months. So often our patients don't recall a tick exposure. And patients often seek medical attention a good couple of times before the correct diagnosis is made, just because, especially given the shifting migratory patterns, Lyme disease or not Lyme carditis is not on the top of everybody's differential. The important part here is because high-degree AV block and Lyme carditis usually resolves with antibiotic therapy, permanent pacemaker is often not necessary in these patients, which is a huge factor in the quality of life because these patients are often otherwise young, healthy, usually male. So back to the case. Our patient started on intravenous antibiotics. You see the progression of their ECG from day 1. We have a second-degree Mobitz type 2. Actually, by day 2, we've progressed to a third-degree AV block. Day 3, we're still in a third-degree AV block. And at this point, we get an echocardiogram, and it shows global hypokinesis and strain, regional wall motion abnormalities, LVEF of 84% in this otherwise really fit young male. He remains significantly bradyc, quite symptomatic, having persistent nausea, chest pain, shortness of breath. And because of this, the patient received a temporary permanent pacemaker on day 3. And temporary permanent pacemakers are really, we highly recommend them in cases of Lyme carditis because of the expected trajectory, and also because then it allows the patients to not lay in bed very still all day. They can up and ambulate around the ward. So day 4, you see that the patient is being paced, and by day 7, we start recovering to a first-degree AV block that is progressively improving. This patient's Lyme serology returned positive, so on their Western blot was positive for IgM antibodies, negative for IgG antibodies, which is quite consistent with an acute Borrelia infection. In terms of treatment, the patient received intravenous ceftriaxone for 9 days, and then we stepped them down to doxycycline. And the point at our institution where we step the patients down is when the PR interval is less than 300 milliseconds. And this patient in particular received 4 weeks of total antibiotic therapy. Prior to discharge, recommended discharge stress test, this patient was able to retrieve a max METs of 13.4, did not have any heart block, had 1-to-1 conduction up to 173 beats per minute. And because the pacemaker was no longer required, it was removed on discharge. In terms of follow-up, there's not too much data in the literature regarding longer-term follow-up of patients who have had Lyme carditis. So at 6 months, we repeated another exercise stress test, similarly 1-to-1 conduction up to 176 beats per minute, and was completely asymptomatic from this. Follow-up echocardiogram showed an LVEF of 63% with normal ventricular contraction and contractility. The 48-hour Holter was unremarkable, and we have follow-up for this patient up to 14 months. He's asymptomatic, and he remains in a sinus rhythm. So for the last part of this presentation, I wanted to overview our systematic approach to the diagnosis and treatment of Lyme carditis. So work from our research group, we first started with this suspicious index in Lyme carditis score. And the score can be remembered by this mnemonic COSTAR. And I just want to take a moment to go through these variables. The C in COSTAR stands for constitutional symptoms. So things like fever, malaise, arthralgia, as I've already mentioned. The O stands for outdoor activity or endemic area, which this patient did have. Here are the endemic areas in Ontario. Ticks causing Lyme carditis are also endemic in places like Japan and Europe. But as I've mentioned, with global warming, changing migratory patterns of the birds that actually carry these ticks, we do see a changing distribution and a widening of the areas that are endemic to the black-legged tick that carries the Borrelia. This patient The S is for sex, male, you get a point for that. This patient in particular recalls a tick bite, so you get 3 points for that, and this patient was less than 50 years of age. The patient did not have the pathognomonic erythema migrans rash, but oftentimes patients don't have that rash, or even if they do, they don't recall it to the initial tick bite event and to their current presentation of Lyme carditis. So this particular patient had a silk score of 8, which is quite high. Our lab has subsequently published in JACC about a systematic approach to the diagnosis and treatment of Lyme carditis, and we have a pretty simple to follow algorithm. So a patient presents with a high degree atrioventricular block, and the first step that you do is you evaluate their silk score. If you have a low silk score, you just proceed to standard treatment for high degree AV block, but intermediate to high silk score, then you go down the possible Lyme carditis pathway, which this patient did. You order a serological test and you start empiric intravenous antibiotics. With respect to their bradycardia, if they're asymptomatic, they need to be in a strictly monitored setting on some sort of telemetry, because they can certainly progress and rather quickly to a high degree AV block. If they are symptomatic, as this patient was, or they have high-risk electrographic features, then we recommend a temporary permanent pacemaker. And then when the Lyme serology comes back, if it's negative, you proceed to your standard treatment. If the Lyme carditis is confirmed, then we suggest continue with intravenous antibiotics for 10 to 14 days, and then followed by a step down to oral antibiotics for a total course of 2 to 3 weeks. If one-to-one conduction is restored by minimum 14 days post-admission, then we conduct a stress test. If it's not, then we recommend consideration of a permanent pacemaker. And the stress test, we have this algorithm that really centers around the point of Wenckebach. If the point of Wenckebach is less than 90 beats per minute, then we'd recommend a permanent pacemaker. If it's greater than 120 beats per minute, then we recommend an outpatient electrocardiogram in 4 to 6 weeks. And if it's between this 90 to 120 range, then we recommend repeating the stress testing to help better risk stratify. So in terms of take-home points, Lyme carditis is an early disseminated manifestation of Lyme disease that may present as high-degree AV block. The AV block in Lyme carditis usually resolves with intravenous antibiotic treatment, which is why we stress early diagnosis, early treatment, and not rushing to put a permanent pacemaker in these people, because if they don't need it over a lifetime of pacemaker changes, infection risk, that's really not in the patient's best interest. The high degree AV block in patients with the initial PR interval longer than 300 seconds really may have an initial worsening while we wait for the antibiotics to kick in, and therefore should be closely monitored during their initial phase of intravenous antibiotic therapy. And in conclusion, a systematic approach to the diagnosis of Lyme carditis in patients with high degree AV block facilitates identifying this usually transient conditioning, and therefore preventing the unnecessary implantation of permanent pacemakers in these young, really otherwise healthy individuals. And I would like to turn my time back over to the organizers, and thank you for this opportunity to speak.
Thank you very much, Dr. Yeung. It was a wonderful presentation. We learned a lot. I have some questions for you, and I will ask you at the end of this presentation, because now it's my pleasure to present Dr. Andres Miranda. He's a brilliant cardiologist from Colombia that now is doing his training in electrophysiology in Canada, and he's going to speak about Chagas disease and the ECG. So welcome, Dr. Miranda.
Thank you so much, Dr. Saldarriaga, for your presentation. It's my pleasure to be here, and then thank you for the organizing committee for having me. I'm just trying to share my screen right now. Second, please. Okay. Please let me know if you can see my screen and if you hear me very well.
Yep, we can see your screen and hear you.
We can see it.
Yes, you can go on, Dr. Miranda.
Well, so thank you so much again. It's a pleasure for me to be presented by my mentor in Colombia, so I'm so happy to be here, and I see a lot of known faces in the audience, so this is exciting to me. I'm going to speak about the ECG changes in Chagas disease, and as you know, this is a topic that is really interesting for me. Then this is going to be my agenda. It's going to be a short agenda. I'm going to discuss why do we speak about Chagas disease at an international meeting? This is a South American disease. Is Chagas a cardiovascular condition or not? And what are those ECG abnormalities in Chagas disease that we need to be aware of? And finally, just wrapping up with a couple of take-home messages. So going to the first point is, why do we speak about Chagas disease in an international meeting like this one? So basically, it's because Chagas disease itself is an international disease. So it's true that all of these points is a neglected tropical disease, it's epidemic in Latin American countries, and 6 million patients are infected in the Americas. However, new cases we see all over the world, mainly because vectorial transmission, but also because of congenital infection. And congenital infection is the main way of transmission in non-endemic areas. There is almost 70 million people at risk of getting infected with Chagas disease all over the world. But the most important is that this is a very expensive disease, not speaking about money only. I mean, it costs almost 10,000 deaths every year, especially in young populations. And it is a very expensive disease when we speak about budget. And of course, it covers a lot of days and causes a lot of discapacity in our young populations. And this is an important message, and this is the main reason why I consider the Chagas is important to be talked in a meeting like this one. This is a world disease, and you see this map is basically we have Chagas cases all over the world. Thanks to migration, the Chagas disease profile changed completely in the last year. So we have a high endemic areas in South America, Argentina, Brazil, and Mexico. Colombia is an intermediate endemic area, but you see cases in United States, Canada, Europe, Australia, Japan, countries that we never thought in the past to see Chagas disease patients. But most importantly is these generations that are now living or migrating to these countries can have, children that can be infected with vertical transmission of Chagas disease. So we are going to keep seeing these patients in the future if we are not aware of this disease. So second point is Chagas disease a cardiovascular condition? And basically, I'm going to go through this slide quickly, but Chagas disease has two main phases, an acute phase and a chronic phase. The acute phase starts with exposition to trypanosoma, and then you can have three options, mainly getting no infection at all, being symptomatic, developing acute Chagas disease, or having an acute asymptomatic infection. If you are one of those patients, not you, but if the patient develop acute disease, there's a 95% chance of getting completely solved. But there's a 5% chance of even dying from acute Chagas disease, mainly for myocarditis or encephalitis. But then the most important point starts here after the resolution of acute infection, and you'll see how after the resolution, some patients will go to intermediate chronic infection, which is going to be asymptomatic. That's the problem. And even if you have asymptomatic acute one, you will develop your intermediate chronic infection. At some point, but reasons that we don't really understand very well, after 30 years of this intermediate infection, we can develop progression to chronic forms. And the chronic forms, the most common is the cardiac disease, which is going to be 20 to 30% of patients. And then we can have also gastrointestinal involvement, and some patients will have mixed, having gastrointestinal and cardiac. And finally, some patients will reactivate with immune suppression, which is time by time more common, being from rheumatic diseases, transplant, or HIV, etc. So, and a couple of important points of Chagas cardiomyopathy are 20 to 30% of patients will develop it, as I already said, and then there's a higher mortality of patients with Chagas cardiomyopathy compared to other patients with heart failure, with other etiologies, even, for example, ischemic disease. And this is here, and this is the point. And why are rhythm disturbances and, of course, the ECG an important key in the diagnosis of Chagas disease is because 60% of Chagas disease patients or patients with Chagas cardiomyopathy will die suddenly. So, And then the second cause will be heart failure, and finally embolism. So yes, Chagas is a cardiovascular disease, and Chagas cardiomyopathy is concerning. And this is a nice picture for this publication in Circulation, when you can see all the spectrum of the potential cardiovascular complications of Chagas disease. Basically, is all in the heart. You can have electrical or rhythm disturbances, myocardium, valves, aneurysms, thromboembolism. So Chagas is a cardiovascular disease, but also we can escalate this, and we can have into account that Chagas is a systemic disease. And just going to the point, so what are the ECG changes in this population? So why is this important? And this is all. So Chagas disease can basically manifest with any ECG abnormality, and we need to be aware of that to start catching our patients on time. So the most common association is right bundle branch plus left anterior fascicular block, but also we can have PVCs that frequently have multiple morphologies because there are multifocal PVCs, non-sustained or sustained ventricular tachycardia, AV conduction abnormalities as first degree AV block or progression to second degree or third degree, sinus bradycardia, and sick sinus syndrome is a common manifestation, but it is always overlooked because it's not considered like the typical ways, but patients with Chagas disease can develop sick sinus syndrome and also get symptoms from this. Left bundle branch block is important because even if it's not so common, when it is present, it's a very bad, I will say, marker of prognosis. Atrial fibrillation as a manifestation of advanced disease and advanced cardiomyopathy is concerning in Chagas patients, and the QRS fragmentation as a sign of a marker of fibrosis. And finally, ST and T wave segment abnormalities. So as you can see here in this slide, basically anything can be seen in the ECG of patients with Chagas disease. So I'm just gonna go through a couple examples here. These are courtesy from Dr. Adrian Baranchuk. But see, you have an ECG which is typical of patients with Chagas disease. You see atrial fibrillation as a manifestation, of course, of left atrial involvement and advanced atrial myopathy. You see borderline voltage, specifically here in limb leads. You see like the voltage is tending to be in the low numbers. You see right bundle branch block here in V1 and AVF, plus the left anterior fascicular, which is almost the most common, but is not the only one. And then you see PVCs here, which are different morphologies and polarities. This is a common ECG. You see everything is there, but there are other ECGs, for example, like this one, when we can see the first thing that caught our attention is in sinus bradycardia. Then we see the association between right bundle branch block and left anterior fascicular block. And another one is just to show, this is again sinus rhythm, but you see how we can notice these Q waves affecting the inferior wall 2, 3, and AVF, Q waves in 1 and AVL, and Q wave in V1 to V3 as a sign of fibrosis. So this is a fibrotic condition, and that's why it is related with the development of ventricular arrhythmias. You see also here low voltage again in 1, 2, 3 AVF, and borderline voltage in the precordial leads. We see here, so you see some partial interatrial blocks. So the P wave itself is lasting longer than 120 milliseconds, but there is no the typical biphasic deflection in the inferior leads of the P wave. And finally, a long QT interval. So all of these could be related with Chagas disease. This is an interesting meta-analysis performed by some colleagues from Colombia, comparing the ECG abnormalities in patients with Chagas disease against general population. And you see that patients with Chagas disease, they present with more frequently left anterior fascicular block, extrasystoles, first degree AV block, atrial fibrillation, complete right bundle branch block with left anterior fascicular, which is the most, I would say, well-renowned association, but also complete right bundle branch block. So in general, patients with Chagas disease, of course, have likely a higher possibility of developing ECG abnormalities compared to general population, but the most important is just start recognizing these changes. And then Besides the diagnostic information that the ECG provides to us in patients with Chagas disease, can we get additional information from it? And of course, there's an important and strong association between some ECG abnormalities and prognosis in patients with Chagas disease. And that's basically because some ECG changes are showing us advanced disease. The progression of the disease can be reflected in the ECG. And what are those changes? So basically, atrial fibrillation and flutter is showing us that the atrium or the atrial cardiomyopathy is advanced. As I told you before, the presence of left bundle branch block is concerning because in 91% of the times, it is related with decreased left ventricle ejection fraction. The presence of third-degree FP block, of course, as a manifestation of advanced AV node involvement in this condition, and the presence of Q waves and low voltage areas as markers of a scar, the presence of fragmented QRS as potential zones of triggering ventricular arrhythmias, and of course, the presence of sustained and non-sustained ventricular arrhythmias are important markers of prognosis in our patients. So this is just to show you, this is the RASI score, which was published in New England Medicine in 2006. This is an interesting study just trying to predict prognosis in patients with Chagas disease from different clinical variables. You see clinical here, clinical components as NYHA classification, markers from X-ray, echocardiogram, but you see here the ECG itself is comparing at least two important markers, as you see the presence of non-sustained ventricular tachycardia and low QRS voltage are markers of bad prognosis and mortality in our patients. And you see just to show you how aggressive or lethal is a Chagas disease, you see here patients with intermediate risk of dying based on this. Let's say patient with non-sustained ventricular tachycardia, low QRS voltage, and just abnormal regional wall motion abnormalities in the echocardiogram will have 8 points. That's going to be an intermediate patient. And you see this patient at 5 years is almost 1 in 5 are going to be deaf. And then at 10 years, almost half of these patients will be deaf. So you see how mortal and lethal is Chagas disease. Finally, just to remark the importance of the ECG in the diagnosis, but also in the follow-up of our patients. This is an algorithm that we presented in the Chagas chapter of the NetHeart book. And you see how once you start suspecting Chagas disease, you can confirm it with the serology testing. And then if the serology test is positive, the next thing you need to do is just have a clinical and ECG assessment of your patient. And if the ECG is abnormal, that's going to be the door to open looking for actively cardiac ECG involvement in our patients, let's say echocardiogram, stress test, or other things that we need to do depending on the clinical presentation of our patients. If our ECG is, let's say, normal, we need to continue following up with ECG as marked here, but also if our echocardiogram is normal, we need to have annual follow-up with ECG in these patients, because at some point the ECG can be the marker of involvement, of cardiovascular involvement in patients with Chagas disease. So just to start to go to the take-home messages, as starting just to close the presentation, is basically, as I told you at the beginning, this is a very common condition, not only in endemic countries. We need to open our minds and start to looking for it in other places of the world. As I showed you in the map, it has a high morbidity and a high mortality rate. The diagnosis in non-endemic areas requires high suspicion. We need to perform additional interrogation, have a nice anamnesis, ask the patient where are they coming from, but also where are their mothers coming from, because that's going to be important information too. 20 to 30%, almost 1 in 3 patients will develop cardiovascular complications from Chagas disease, and the ECG is going to be the cornerstone for diagnosing Chagas cardiovascular involvement in patients with Chagas disease. And as I told you, and as I showed you, is not only right bundle branch block plus left anterior fascicular block, is almost any manifestation in the ECG, say bradycardia, atrial fibrillation, low voltage, Q waves, signs of scarring based on QRS narrowing or slurring, or other ECG abnormalities that can be even prognostic as the development of non-sustained ventricular tachycardia or ventricular arrhythmias. So it's an important prognostic factor and marker that we need to take into account. That's all I had, and thank you so much, and open for questions.
Thank you very much, Dr. Miranda. Wonderful presentation. We learned a lot. And you teach us that Chagas now is everywhere. It's not a South American problem due to migration. So your key points are very important to remember. So now let me introduce Dr. David Chieng from Canada also, who is going to speak about a very important thing, which is COVID and the ECG. All of we learned a lot in times of COVID. So now the screen is all yours, Dr. David Chieng.
Can you guys hear me okay?
Yes, we can see your slides.
I guess firstly I want to mention that I'm not from Canada, I'm from Australia, and it's really early in the morning, but that's okay. So I want to thank the organizers for inviting me to speak about this interesting topic, COVID and ECG. And just to briefly mention, I'm one of the EP fellows at the Alfred and the Baker Heart and Diabetes Institute in Melbourne, Australia. So I thought in this next 10 minutes, I'll just cover 3 areas briefly. Firstly, talking about COVID-19 disease and the associated cardiac complications from it, and secondly, to describe about what are the perhaps ECG abnormalities in COVID-19 patients, and lastly, talking about prone versus supine ECG comparisons, particularly in COVID-19 patients who require prone ventilation. So as of yesterday, when I look it up, the COVID-19 pandemic has infected more than 500 million people worldwide, resulting in more than 6.3 million deaths. And COVID-19 patients who are hospitalized, they tend to be older and have more cardiovascular comorbidities. And I think most of us are aware that COVID-19 disease is associated with increased risk of cardiac complications. And there was a publication by Lala back in 2020 in JACC, which describes a prevalence of myocardial injury as manifested by a rise in troponin levels in 36% of COVID-19 patients. And there's several potential mechanisms that can account for this myocardial injury, including systemic inflammatory response or SIRS, the presence of macro or micro thrombi in the circulation, and also demand supply myocardial ischemia as well. In addition to that, patients with COVID-19 disease are also at increased risk of ST elevation myocardial infarction, and these patients tend to have a worse prognosis as a consequence of their ST elevation MI. In addition to that, patients with COVID-19 disease are also at increased risk of arrhythmias. And in this publication by Peltzer back in 2020, the most common arrhythmia was atrial fibrillation or atrial flutter. And the overall incidence of arrhythmia is approximately 25.6%. Now moving on to the second bit, what are the potential ECG abnormalities in COVID-19 patients? There was a paper by Bettini back in 2020 looking at 431 patients who were hospitalized with COVID-19, among which 24% were on mechanical ventilation and 35% were on non-invasive ventilation. And basically what they found was that ECG abnormalities was present in 93% of the cohort, with the 4 most common features being non-specific repolarization abnormalities, QTc prolongation, pressure overload on the right ventricle, and atrial fibrillation or atrial flutter. However, a weakness of the study was that of these changes that they saw, they were unable to tell whether these were pre-existing or whether they are new onset ECG changes in relation to COVID-19 disease. And this is just an example that was included in the paper, patient with COVID-19 disease, and essentially is evidence of right ventricular pressure overload with the presence of right bundle branch block, atrial flutter as the underlying rhythm, and also the presence of RV strain with an S wave in 1, Q wave and T wave inversion in lead 3. More recently, Sabelloni and colleagues published on the prognostic value of 12-lead ECGs in patients who were hospitalized with COVID-19. And this was a retrospective single-center study involving 190 patients, of which 24 patients died. And they found that features on ECG, they were consistent with an increased risk of mortality were QTc prolongation in excess of 451 milliseconds, the presence of RV strain, and atrial fibrillation. And these three findings are remarkably similar to the findings that were found by Bettini 2 years prior. Now, COVID-19 doesn't just affect the heart, and we know that patients who have severe respiratory failure because of acute respiratory distress syndrome, in these patients, prone positioning, where they are placed onto their belly together with prone ventilation, this can significantly improve their oxygenation levels and reduce the need for intubation as well. However, as you can imagine, Lyme patients in a prone position imposes practical challenges to acquiring a 12-lead ECG, which is conventionally done in supine position, and trying to reposition these patients increases the risk of respiratory compromise. A prone ECG, particularly with the precordial leads attached to a patient's back, avoids the need to reposition them. However, the effects of this prone ECG on how the ECG looks like remains unknown. And what we did back in 2021 was that we compared 12-lead ECGs done in prone and supine positions, and what are the potential implications for those who require prone ventilation with COVID-19 disease. So what we did was a prospective multi-center observational study, and we took 100 patients and we did 3 ECGs in the exact same sequence for each patient. So the first ECG is the conventional supine 12-lead ECG with the precordial leads attached on the chest, with V1 and V2 in the 4th intercostal space and V3 to V6 in the 5th intercostal space. From here on, I'll refer to this as the supine front ECG. And then we turn the patients onto the belly, but we kept the precordial leads in the exact same position on the chest, and this is called the prone front ECG. And then for the last ECG, we move the precordial leads to the back and attach it in an exact mirror image to the position on the chest, with V1 and V2 approximating the 4th intercostal space anteriorly, and V3 to V6 approximating the 5th intercostal space anteriorly. This is also known as the prone back ECG in this study. So firstly, with regards to the PR interval, we found that between the supine front position and also the prone front position, they were highly correlated with no significant differences between them. And similarly, between the supine front and prone back, there was no differences between them as well. With the QTc interval, we found that, again, there was a very high correlation between the supine front and also the prone front position. However, there was a numerically small but statistically significant increase in the QTc interval when changing from a supine front to a prone front position. And a similar pattern was also seen when we go from a supine front to a prone back, with, again, a very small but statistically significant increase in the QTc interval by changing to a prone back position. This graph here describes the changes in the QRS morphology when patients go from supine front to prone back position. And I'll just highlight the main points here. So in the conventional supine front, as expected, the typical morphology predominantly is an RS pattern in V1 to V3, present in 3/4 of patients. When you go into a prone front position, in about 1/3 of patients, you will see a slight delay in terms of the precordial transition. However, the main finding was that in a prone back position, in 90% of the participants, there was a new change in the form of a QR morphology in V1 to V3, particularly in those who have a baseline normal ECG. 92% of them will exhibit this new QR morphology in V1 to V3. So I'll show you this example right here. So we got a patient lying in a supine front position with the RS morphology in V1, and by changing onto a prone back ECG configuration, what we see was a QR morphology in V1 instead, which mimics a potential anterior septal infarct. With regards to ST segment, at baseline, there were 37 participants who had abnormal ST segment, either in the form of ST elevation or ST depression. In a prone front position, just over a quarter had changes in the ST segment, which mostly consisted of changes, either resolution or a change in amplitude of the ST segment abnormality, but in the same leads. In a prone back position, 78% of them had changes in the ST segment. So where were these changes in the prone back? And again, I'll just summarize the main findings here. So in those who've had ST elevation or ST depression in V1 to V3, in a prone back position, all these ST segment abnormalities were no longer visible in every single case. Whereas with ST elevation or ST depression in the lateral or inferior leads, the majority of them still retained their ST segment abnormality, and only a small proportion had resolution of the ST segment abnormality. And here I show you an example right here. So a patient with anterior STEMI, as you could see in the supine front position with ST elevation in V1 to V3, in the prone back position, those ST segments were essentially not observable. Now talking about T wave, at baseline, 42 participants had normal T waves. However, in a prone back position, about 3/4 of them developed changes, particularly in the form of a negative or flat T wave morphology in V1 to V3. There were 58 patients who had abnormal T waves at baseline, and in a prone back position, the majority of them, or 91% of them, had changes in the T wave polarity. And again, where were the changes seen? I'll just summarize the main findings here. In those who have T wave inversion in V1 to V3, the majority of them had a positive or flat T wave appearance in V1 to V3. Whereas those with T wave inversions in the lateral precordial leads, or the lateral leads, or the inferior leads, the majority of them develop a new negative or flat T wave in V1 to V3. And here's an example right here. So we have a patient with a prior anterior STEMI with T wave inversion in V1 to V3, as seen right here. In a prone back position, the T wave had flipped in terms of polarity to become positive in the same corresponding V1 to V3 leads. We had 7 patients with left bundle branch block, which was still visible in a prone front position. However, in a prone back position, interestingly enough, the main appearance was a right bundle branch block morphology in 3/4 of them. And in those with underlying right bundle branch block at baseline, in a prone back position, what we saw was a narrowing of the QRS, which was statistically significant along with a new QR morphology in V1 to V3. Again, I give you an example right here. So we have a patient with left bundle branch block in a conventional supine position, in a prone back position. What we saw was mainly a right bundle branch block appearance. And similarly, in a patient with right bundle branch block at baseline, in a prone back position, what we saw was a narrowing of the QRS associated with a QR morphology in V1 as well. We had 10 patients with arrhythmia at the time of the ECG recording, and all of this was successfully detected in all 3 ECG positions. And recently there was a publication, this was about 2 months ago, describing a new method for recording ECG in a prone position. And basically what it did was to place the precordial leads in the antipodal location on the back. So V1, the antipodal location was down here, and what I call the M1 or mirror 1. V2 became M2, M3, V3 became M3, V4 became M4, and V5 became M5. So by placing these in the antipodal location, you basically go from the 5th intercostal space on the left-hand side, and you work your way up to the left intercostal space at the second position. And what they found was here, so this is how the ECG looked like in a standard supine position, V1 to V6. The recording from the antipodal location was here, and you could see that the P wave, the QRS, and also the T wave were inverted compared with the standard precordial position. However, if you invert these mirror leads, it looks quite similar to a standard supine precordial lead positioning ECG. So to conclude, I've basically aimed to describe 3 main things. Firstly, COVID-19 disease is associated with increased risk of cardiac complications. And secondly, in those with COVID-19 disease, some of the common ECG abnormalities that could be encountered are repolarization changes, QTc prolongation, right ventricular pressure overload, and also arrhythmias. In those who require prone ventilation for severe respiratory failure because of COVID-19 disease, in our study, we found that this prone back ECG configuration is useful for the detection of ST or T wave abnormalities in limb leads. It's useful for bundle branch block detection and also for rhythm monitoring. However, it is unreliable for the detection of anterior myocardial injury. So thank you so much for your time today.
Thank you very much for your presentation. It's a very interesting topic, as I mentioned before. So now let's move to our last speaker, which is Dr. Hector Ortiz from Guatemala. He's going to speak about the NET-HEART project. a very interesting program that had several papers and also the NetHeart book from the Inter-American Society of Cardiology and also from the work of all the emerging leaders from the Inter-American Society of Cardiology. So Dr. Hector Ortiz, so now it's your time to present your topic.
Hi, can you hear me?
Yes.
Hi, everybody. I'm Pilar Lopez-Santi. I'm from Argentina. First, I want to congratulate you all for your presentations. I think they were super nice and super clear. I have some questions. I don't know, maybe first I can ask Cynthia Yeung. I wanted to ask you if in your experience with Lyme disease, the history of cardiac conduction abnormalities during the disease is how does it function as a long-term predictor during the follow-up? I mean, a person with Lyme disease that presented cardiac conduction abnormalities, which is the prognosis in long term?
Yeah, that's a fantastic question. Thanks for answering that. So I think that's a really interesting question because our experience and our data in Lyme carditis is nowhere near as substantial as it is, say, for Chagas disease. And our research group actually recently did essentially a literature review comparison of the two diseases. And Chagas disease has decades and decades of history. Whereas Lyme carditis really kind of came more into the forefront and more into scientific literature really in the last like 2 or 3 decades. All this is to say, we don't know and we don't have the data. And that's actually the specific research question that our research group is now very interested in looking into, because Kingston being a highly endemic area for Lyme carditis, we have a database where we're collecting patients who have come through our center of peripheral hospitals with Lyme carditis, and we are working on long-term follow-up. Although a very small database right now, I believe our median follow-up is on the order of approximately just 2 years now. And for the most part, patients who have recovered from Lyme carditis up to median follow-up of about 22 months, we're not seeing any long-term effects. Of course, with things comparing to things like Chagas disease, the long-term manifestations of the cardiac effects are really decades out, and we just simply don't have that data. But I think it's a really interesting question that will take some time to follow up and answer. Okay, thank you.
Thank you.
So maybe Juan, Farina.
Hey,
Yes.
Hey, how are you doing? Congratulations to everyone.
So,
Congratulations to everyone from presentations. I have a question for Andres. You mentioned that sudden cardiac death can be like a really important problem in Chagas disease, and you mentioned that we have some tools to predict the risk of overall mortality in Chagas. Do we have like specific tools to predict the risk of sudden cardiac death or malignancy? Speaking about ventricular arrhythmias in Chagas, that's the first part of the question. And the second part will be if we need to consider some specific recommendations for the use of ICD in these patients, or if we just follow the general recommendations. Thank you.
Thank you so much, Juan. That question is a great question. And then a couple of things. So the first question is, we do have some tools to predict the risk of sudden cardiac death in Chagas patients. So mainly scores. So RASI score is one of them. We have also a SOSA score, and there is another score trying to predict sudden cardiac death in this population. All of them are mainly based in the same variables. So saying a functional class, NYHA, so showing us that the worse the functional class in these patients, the higher the risk of sudden cardiac death. ECG abnormalities, and interesting there is just they are crossing, for example, the presence of a non-sustained VT, and the QT interval is present in one of them. So, which is interesting too. So, because we are not expecting this condition to, in this condition, long QT, being a marker of bad prognosis, but it is in some scores. And also some of them include the presence of syncope, for example, in patients with Chagas disease. Despite that syncope in this population sometimes could be explained by the autonomic dysfunction, because these patients also had that complication. So, and there is something that is changing in the next year, in the last years, is that considering the also not only Chagas in cardiovascular complications and gastrointestinal complications, but also it is well known that there is a neurologic involvement in Chagas disease, specifically of autonomic nervous system, which can be also implied in the development of ventricular arrhythmia. So it's not only scar, it's not only fibrosis, it's also the autonomic influence in the heart. And also syncope could be explained by that, but it's included also in some prognosis scores. So yes, so we have some scores, some tools. Some of them are just multi-component clinical ECG and echo findings. And the second question is recommendations for ICD. That's a very good question, Juan. Is mainly the responses. Nowadays we only follow the general guidelines for ICD in patients with heart failure, being driven by left ventricle ejection fraction and NYHA classification for the primary prevention, and also the presence of optimum management of atrial fibrillation, or in secondary prevention is any patient with Chagas disease that has had in the past an episode of unstable ventricular arrhythmia or an aborted sudden cardiac death. The point here is that there are a lot of questions in the primary prevention especially. So what is optimal medical management in patients with Chagas disease? I mean, is the same medical management in patients that cannot tolerate the management sometimes? So that's a good question. And it's only the left ventricle ejection fraction, the factor that we need to take into account in these patients when we've noticed from previous scores that, for example, just regional wall motion abnormalities, the development of apical aneurysms are markers of higher risk of sudden cardiac death, as you saw, for example, in RAS score. So there is interesting things that we don't have specific data, but there is a lot to go through that. Thanks, Juan.
Okay, so Pilar has a question.
Yes, I have a question for Andres. First, congrats on your presentation. It was really good. And related to what you previously said, I wanted to ask you if stress testing is a good tool for predicting sudden death in patients with Chagas disease.
Well, that's another fantastic question. I think all questions are fantastic because I really like this topic. So yeah, it is a good marker of prognosis. Couple of things that can be seen in that test are, one thing is these patients also had risk of sick sinus syndrome, so we can see chronotropic response and the behavior of the sinus node during the stress test, and also we can start seeing the ventricular arrhythmias on exercise, and we see if we can induce ventricular arrhythmias, non-sustained or sustained VT episodes during the exercise stress test. That's going to be an important risk factor in this patient. So it's definitely a useful test.
Perfect. Thanks.
I don't know if maybe Juan has
I have
a question for Chieng.
I have a quick question for Cynthia Yeung that I want to know about the case that she presented.
Okay.
Congratulations for the presentation. That was great. I mean, you showed the echo of this patient, and the patient that you showed us had like a kind of myocardial involvement with like a left ventricular ejection fraction below 50. My question would be how frequent it is to find the AV blocks with a complete normal echo, a complete normal LV function. I don't know if that's a clear question, but without myocardial involvement, just the AV block.
That's a fantastic question that I do not know the answer to because, like I said, I don't think there's enough data. There's not enough publications on it. I think most of the literature has focused on the electrical conduction abnormalities. And I think that really has to do with where the spirochete likes to affect in the heart, which is really, it has a predilection for affecting around the AV node, which is why we see a high degree AV block as the main manifestation. And it also has a predilection to affect the base of the myocardium, hence why we saw a little bit of an inferior myocardial abnormality on the echo. But I don't think that we have the data on the echo findings for large cohorts of Lyme carditis patients.
Thank you very much. I'm going to ask the last question for Dr. David Chieng, and then I will move to Dr. Hector Ortiz who is going to briefly tell us what is the NetHeart project, because we have difficult problems and technical problems with the presentation. So Dr. Chieng, you showed us a lot of ECG changes associated to COVID infection. My question is that a direct effect of the virus? Or do you think that this is just the reflex of the so many cardiac manifestations that the virus can have?
Yeah, I think that's an interesting question. I think the bottom line, I guess, is we don't actually know 100%. You know, all those changes that are described by papers, you know, by Bettini and so on. Part of the weakness was that they don't know for sure whether these changes were present before or only after the COVID-19 diagnosis. But I guess, you know, when you have several papers that describe several adverse prognostic features on ECG in COVID-19 patients, I think it's I guess it's fair to assume that, you know, in some proportion of these patients, those changes that we talk about, those QTc prolongation, the RV pressure overload, I think it's reasonable to assume that in a proportion of patients that these are, you know, due to the manifestation of COVID-19 disease itself, I think. So yeah, I think it's hard to know 100%, but my guess would be that in a proportion of them, the COVID-19 illness itself does result in these ECG changes.
Thank you very much. So now, the last minutes of this session, I'm going to give this time for Hector Ortiz from Guatemala to tell us about the NetHeart project. Just a briefly summary to what was done and the implications of this very interesting work.
Hello, everyone. I'm sorry for my technical problems. My presentation says file corrupt. Sorry, I am not aware about that. Maybe I have a problem with my office, but I apologize in behalf of myself. Sorry. The NetHeart project, it was an interesting vision, an interesting point of view of our teachers, our colleagues that are Clara Saldarriaga and Dr. Adrian Baranchuk, to put all the neglected diseases, infectious diseases, and their impact in the heart, in the cardiovascular heart, you know. So was a very interesting project, was a very hard project because it was very easy. And I think Andres and Juan, Farina, and even Dr. Clara Saldarriaga can say about that. That was a hard project to plan it, to develop it, and to see the outcome, the final outcome, to see all the book that we made. The project also come to the idea to make papers, individual papers, and then to join them together to make a book of infectious diseases and the important electrocardiography outcomes. So it was very, very interesting project. So we gathered infection diseases that are rare, that are very interesting diseases. For example, the American trypanosomiasis that Andres talked minutes before, also are diseases that are very rare, and the cardiovascular affections are super interesting. So I apologize because I have some slides to show how the project developed and what was the main idea of made it. Each individual paper are available online, and all the book is available online. But the work that we gather from all the cardiologists of the zone of the Society of International Cardiology from Colombia, Argentina, Canada, and even though they help us medical students. So it was a very interesting project, and Juan can also can talk about how was his experience about making that project.
So Juan, can you mention something else about this?
Oh yeah, I think that Hector already mentioned the most important things, but yeah, basically it was a project that was like carried on by the Emerging Leaders Program of the Inter-American Society of Cardiology, and we wanted to review and systematically review the cardiovascular involvement in neglected tropical diseases. These diseases are more frequent than what we really thought in the past. They are frequent condition that mostly, and yeah, what it's really interesting that these conditions, I mean, mainly affect populations living in poverty, living in low and middle income countries, and almost every time these populations, they have like several barriers in order to access to healthcare or to access to clean water. So that's why we thought that it was really important to study these conditions and to review these conditions, mainly because we are almost all of us that we are part of the Inter-American Society of Cardiology, we are working in this setting in the low and middle income countries. So that's why we wanted to review these conditions. A couple of important findings, I think, for our project is that there is still a lot of work to do. And then there are a lot of underdiagnosis and underreporting barriers in our countries. A lot of people, they have these diseases, they have cardiovascular involvement due to these diseases, and they are not able to access to the healthcare physician in order to make a correct diagnosis and treatment of these conditions. And another barrier that we have is the underdiagnosis. A lot of physicians, they are not aware about the cardiovascular involvement of these diseases, so sometimes they don't look for them. So if we don't look for the cardiovascular complications, we are not going to find them. Another brief message is that we were able to create not only the papers and the book, but we also included in the papers like original algorithms in order to diagnose and treat these conditions, and we think that that can be really important for physicians working with these conditions all around the world. And I mean, first phase, it was the development of the papers. Second phase, it was the development of the NetHeart book. And we have a third phase that we are working on. We are trying to develop an application for mobile devices. We wanted to include the most important information about cardiovascular involvement in these diseases in the app. And we also want to include the algorithms in the app in order to facilitate this information to the physicians working with these conditions, even in remote areas. And the idea is that the physicians working with these neglected conditions can access to the algorithms from all around the world. So that's basically the project. We have up till today 15 papers published in PubMed and Medline Index journals. So we're super happy with the first phase. The NetHeart book was published last year by Elsevier, so we are super happy with that also. Hopefully we will have the NetHeart application in the near future. So yeah, thank you very much. I think that's all that I can say.
So thank you very much, Juan, and thank you very much, Hector. I think that due to this project today, the awareness of these neglected tropical diseases around the world is increasing, and this is our contribution to that problem. So I would like to thank all the presenters and our panelists. I think it was a very productive session where we learned a lot about ECG changes in infectious diseases. And I think that's it.